Hello, my name is Mohammed Sabra and I'm a first-year cardiology fellow at Henry Ford Hospital. Today, I will be presenting the case of an implantation of a leadless pacemaker in a patient with inferior vena cava filter. We have no relevant financial disclosures. Leadless pacemakers are typically implanted using the transfemoral vein access approach. A common limitation for this approach is the presence of an IVC filter, especially when stenosis or occlusion is present. Today, we will present the case of a patient with an IVC filter whose leadless pacemaker was placed via an alternative access route. A 65-year-old male with a past medical history of previous polysubstance use disorder and an IVC filter placed several years ago for an old deep vein thrombosis who presented to the ER with fatigue and dyspnea on exertion. Patient was found to have a high-grade atrioventricular block with an intermittent complete heart block, as shown in Figure A on the next slide. Patient had very poor dental hygiene, lived in a homeless shelter, and was known to have poor medical compliance. His workup was negative for infective endocarditis. A Medtronic Micra AV pacemaker was felt to be the best treatment approach for this patient. Ultrasound-guided right femoral vein access was obtained and a guide wire was advanced into the IVC, but we were unable to further advance beyond the IVC filter. An IVC venogram showed complete IVC occlusion with collateral, as shown in Figure B on the next slide. We discussed the options of subcutaneous transvenous dual-chamber pacemaker versus a Micra AV pacemaker using a right IJ access. We decided to proceed with the Micra AV placement. A temporary pacemaker was placed from the left IJ. Then, the right IJ vein was also accessed using ultrasound, and the guide wire was advanced into the IVC. The Micra was advanced into the right ventricle and placed into the septal wall, as shown in Figure C and D, with appropriate device measurements, and the device would optimize for AV synchrony. The right IJ access was closed with figure of 8 suture. At 3 months follow-up, the patient still had normal device function. Several cases have been reported about the ability to place Micra pacemakers through an IVC filter. At our institution, we have had successfully placed a few Micra pacemakers in patients with IVC filters without any issues. Implantation of a Micra pacemaker through an IVC filter can affect the integrity of the filter due to right lateral forces exerted on the filter. A Micra pacemaker can be safely implanted via a superior approach from the right internal jugular vein. However, femoral approach should remain the standard due to concerns of advancing a large sheath through the right internal jugular vein and the increased axial forces through the right IJ. In conclusion, in a patient who is felt to be most appropriately treated with a leadless pacemaker implantation but has an IVC occlusion that renders a femoral/IVC approach unsuitable, alternative transvenous access can be used, as we used right IJ access in our case.